continuing from lecture 6. Mitral valve closes, that will produce S1 sound. Aortic valve closes, that will produce S2 sound. Now in the left ventricular volume and left ventricular pressure, okay, for PV loops, the mitral valve first that will close, right? Then aortic valve will open, right? And over here the volume is remain the same, right? And the pressure will rise, so isovolumic contraction. Then volume will decrease, aortic valve will closes, then mitral valve will open, right? Again the volume will increase. And over here in this graph, mitral valve, the first one that is open, right? So the volume will increase, then the mitral valve closes, that will produce S1 sound. Then aortic valve will open, right? Then the volume will be decreased, and again aortic valve closes, that will produce S2 sound. Okay, this one is representing systole with red and with green diastole. Okay, preload is in the bottom, afterload is in the top. Preload changes increase, so if it is increased, it will increase in diastolic volume. Stroke volume will be increased, due to which ejection fraction will be slightly increased, since stroke volume is equal to end diastolic volume minus end systolic volume, so ejection fraction equals end diastolic volume minus end systolic volume by end diastolic volume. When your preload is decreased, then the end diastolic volume will be decreased, stroke volume will be decreased, ejection fraction will be slightly decreased. Again, stroke volume equals end diastolic volume minus end systolic volume, ejection fraction equals end diastolic volume minus end systolic volume by end diastolic volume. When afterload changes, if it is increased, end systolic volume will be increased, due to which decrease in stroke volume, due to which decrease in ejection fraction. Whenever contractility is decreased, then it will be shifted to the right and will be decreased, so end systolic volume will be increased, stroke volume will be decreased, ejection fraction will be decreased. It is for decrease in contractility. Whenever contractility increases, that will shift to the left side. End systolic volume will be decreased, so the difference will be increased between end diastolic and end systolic. So stroke volume will be increased, due to which ejection fraction will be increased. Compliance changes. Okay, if the compliance is decreased, that will move toward the left side. So end diastolic volume will be increased, but end diastolic pressure will be increased. Okay, the one with green is of greater work, and the one with red is of lesser work. The area is low. This is for aortic stenosis, because the pressure after load is high. Mitral regurgitation, isovolumic contraction is disrupted. Aortic regurgitation, isovolumic relaxation is disrupted. Mitral stenosis, ventricles cannot fill properly, so end diastolic volume will be decreased little bit. Then we have Vegas diagram. Okay, EKG and venous pressure, heart sound is 1 is 2. Then left ventricular volume. Okay, then with that of pressure, aortic pressure, left ventricular pressure, and left atrial pressure. Okay, good. Okay, the mitral valve closes, that will produce S1 sound. So then there will be rise in pressure, in ventricular pressure. When it is greater than aortic pressure, it will open aortic valve, then it will goes down. When aortic pressure is greater than ventricular pressure, that will close the aortic valve, that will produce S2 sound. Then again in the down region, the left atrial pressure will be increases than uh, ventricular pressure, that will again open the mitral valve. So in case of aortic stenosis, the ventricular pressure is raised. Okay. Then in mitral stenosis, the left atrial pressure will be raised. Then in mitral regurgitation, okay, the left atrial pressure will be increased, right? Okay, normally it is not that much increased, but here will be increased more. Then in aortic regurgitation, the pulse pressure will be raised. Okay, then we have A wave, C wave, V wave, atrial contraction, A wave, then V wave, venous swelling, C wave, tricuspid wall closes, then X descent, and then X descent is for atrial relaxation, Y descent for emptying of the atrium, and it V, the tricuspid wall opens, so pressure will fall. Venous pressure between C wave and V wave, we have no right ventricular filling, right ventricular contraction. Then V wave and C wave, we have right ventricular filling and right ventricular relaxation. Okay, we talked about this. So when contractility raised or peripheral resistance decreased or afterload increased, so stroke volume will be increased. Contractility decreased, stroke volume decreased. Peripheral vascular resistance or afterload increased, stroke volume decreased. Okay, with heart failure, so contractility would be decreased, right? With that, cardiac output will be decreased, and total peripheral resistance will be increased, and there will be increased fluid volume. Okay, so the cardiac output is decreased, and with that, the right atrial pressure will be increased. In case of hemorrhage, there is blood loss and increased TPR and increase contractility. Overall, the cardiac output would be decreased and right atrial pressure would be decreased. In exercise, decreased TPR, venous contraction would be increased contractility, that will lead to increased cardiac output. AV fistula is the same as that of exercise. Combined curves, right, for a patient on Starling curve A with a mean MSFP of 10. What is the cardiac output? That will be less than 5. Okay, good. Now left ventricular pressure changes his left ventricular change his biggest spin. If we compare it with the left atrial pressure and aortic pressure, A wave pressure goes high in right atrium. C wave, that is tricuspid valve closes. V wave, venous return increases, then tricuspid valve opens. Large A wave, that is associated with tricuspid stenosis plus right heart failure plus pulmonary HTN. Canon A wave, atria against closed tricuspid valve, AV dissociation, complete heart block, premature atrial contraction, premature ventricular contraction, and ventricular tachycardia, not associated with each heartbeat. Absent A wave, no organized atrial contraction in atrial fibrillation. Giant V wave in tricuspid regurgitation. Major parameters that shift Starling curve are contractility and peripheral resistance, that is after load. Contractility decreases in case of MI and heart failure. TPR decreases in sepsis. Right atrial pressure is inversely related to venous return. Right atrial pressure is inversely related to venous return. Volume and venous tone shift venous return curve to left or right. Volume and venous tone shift venous return curve to left or right. TPR change shifts curve left or right but no change in MSFP. Pressure in the left ventricle when the heart stops working. Result is change in slope of venous return. Venous return or stroke volume or cardiac output is inversely related to right atrial pressure. Combined Starling in venous return curves. In heart failure, fall in cardiac output but rise in right atrial pressure. In hemorrhage, cardiac output and right atrial pressure both decreases. During exercise, cardiac output increases. AV fistula, same as exercise. Primary mechanism is decrease in TPR. Vasopressors, low cardiac output with change in slope of venous return curve.